So this is just a little bit of just a little adjustment in the topic area. So today we have with us another faculty member from MUSC, Dr. Kathleen Lindell. And I met Dr. Lindell at an healthy aging conference about a year or so ago and heard her talk. And I thought, we need to bring her here and talk to our patients. So her background, she's currently an associate professor and a Mary Swain Endowed Chair in Palliative Care Health here at MUSC, the College of Nursing, and has a joint.
Sorry. I'm going to turn it.
Powerful. Is it on?
Mm-hmm.
You can mute it here. It's the number one, I think. Okay. So just a little background. So Dr. Lindell, I've lost my place. So she worked at the Penn Lung Center and Pulmonary Clinic, clinical nurse specialist, as a clinical nurse specialist, where she participated in developing evidence-based. But it feels like I'm getting bounced back here, so I feel like I'm talking twice. But she developed some evidence-based programs, which I think is really your big interest is developing these programs to work with patients. And I think I'm too close to your mic. There we go.
Yeah.
And she initiated this work up at Pittsburgh, right? University of Pitt. And then came, and I'm going to cut this short. Just
I was going to say,
yeah.
I can
Yeah.
introduce myself
Yes.
too.
But she brought this work down to MUSC and has brought this palliative care work here, which is a really important topic for us as patients. We may really misunderstand what it is and how it can serve us. And so she's going to share with us more information about this as a strategy for us to help us have quality of life throughout the life course of somebody with scleroderma. Some of us have lived a long time with scleroderma, and there are many things that we should take advantage of to say, how do we want to live in the time we live? So thank you, Dr. Lindell. I'll let you fill in the blanks for me.
So can you hear me online too? So thank you for this opportunity to be here. I have been a nurse for 47 years. I graduated when I was 10. No, I'm teasing. No, but I originally am from Pittsburgh, and I went to nursing school at St. Francis General Hospital in Pittsburgh. So I'm a diploma nurse by my background. But those nuns really just like beat it into us that we were to take the best care of patients who we were privileged to care for. I went on and I was originally a critical care nurse, and then I went on and I got my bachelor's and then master's degree in pulmonary nursing at the University of Pittsburgh. So my area of interest is working with patients who to promote lung health and to help when they have disease, and also their caregivers. So for 10 years, I worked at the University of Pennsylvania in the Penn Lung Center, and I really garnered a lot of experience working with general lung disease, and that was my entree into advanced lung disease or chronic respiratory disease. And then I came back to Pittsburgh, and I was there for 20 years, and we started a program. A donor gave us $5 million in the year 2000 to start a center. The center had three, it was called the Dorothy P. and Richard P. Simmons Center for Interstitial Lung Disease at the University of Pittsburgh. So I was the clinical nurse specialist with two pulmonologists, and the donor gave us these three charges: find the cause, find the cure. And my charge was to provide education and to build a support group. So I went to clinic every week with the physicians, and I would see patients. I'd do their history, and then I'd do their care plan. And I also started the patient support group in 2001. And that I learned so much from that patient support group. Every time I heard today somebody saying about support group, support groups and patient education events like this are critical for your knowledge. I started my PhD when I was at Pitt, and I did a study because my research question was, what is the disease impact of pulmonary fibrosis on patients? So I studied 28 patients who had idiopathic pulmonary fibrosis, which that's not what you have. But just to give you for context, idiopathic pulmonary fibrosis is unknown lung scarring. And there's no known cause, there's no known cure, and the lifespan is 3 to 5 years. So this was back in, early 2000s. And I realized we weren't really doing the best that we could for our patients. And patients were suffering with symptoms. And so there was a lot more. So that really like lit my fire, is how do we help these patients? So what those patients in that first study told me, they completed questionnaires. They were depressed. Over 50% were depressed. And 3 of them were severely depressed and had suicide plans. And it was because it went down to, because they didn't know what to expect moving forward, but they knew they felt really poorly. Now, if they had good social support, meaning they had family and friends who loved them, they had a better quality of life. Just what you think, but no one had looked at this yet. So I went on and I studied disease. I created a disease management program for patients and caregivers, and we studied that. And patients came for 6 weeks in a row with their designated caregiver, and they learned all about their disease. And that was published in 2010. And what we learned there was that we had speakers. We had myself, we had a psychiatric clinical nurse specialist come and talk to dealing with your feelings. Okay, well, so now you have this diagnosis. How are you going to live with this? So she gave them really great practical tips. We talked about advanced care planning, which every single person should be doing and not be afraid of. It is the best gift you can give your loved one, to know you get hit by a car, or you're in a car accident, or you get a serious illness. What is it that I want when I can no longer make my decisions? So we taught patients about all these things. Well, it was 6 weeks in a row. And on the 6th session, I had all the teachers come back, and I said, well, we're here to answer your questions. And they all went, we're good. We don't have any questions. And we're like, and we just want to talk to these other people. So my dissertation committee said, you're not done yet. So I went and I did home visits across Western Pennsylvania for my next semester. And I traveled it was a 100-mile radius to go to people's homes and to interview patients and caregivers separately. And what was it about this program that why did they rate? Because what they did is I gave them a survey, and they wrote, everyone who gets this diagnosis should have to take this course. And that's what my dissertation team was like, you gotta like dig into that and see what's going on. So the first one, I go to this gentleman's home. He just started on hospice, and he was a retired engineer. And he said to me, can I tell you something? He said, I didn't know what the word idiopathic pulmonary fibrosis meant. He said, and then in your course, you said idiopathic pulmonary fibrosis equals unknown lung scarring. And he said, oh, why didn't they just tell me that? So we learn from you, and we hope to teach you too. And he said that where he lived was a rural area, and he's like, I gave them a binder and every week they got information about their disease. He said, I taught my visiting nurse about my disease because she didn't know what I had and what it was. But the takeaway is these patients collectively said when they got the diagnosis, they go home and their community of caring people around them would say, well, what did they say you have? They're like, I don't know. I can't pronounce it. And so they were confused. They said by being in this group of other people with the same problem, it gave them perspective. Like, and that was a double-edged sword. Like, oh, wow, I'm not as bad as that guy. He's on a lot of oxygen. Or, oh, that could be my future. Caregiver stress decreased significantly because the caregivers knew what to expect going down the road. That was our biggest finding. And then most importantly, the patient said, it may not help me, but it's so important to participate in research to help people down the road. So that kind of was my start. And it wasn't what I called palliative care, but it was palliative care. And so we're going to talk about that. But what happened is then over the next several years, I launched my research career based upon that. And I very luckily got accepted to this 1-week course at the Virginia Commonwealth University, where I took this palliative care course for advanced practice nurses. And it was after that week, I was like, this is what I'm supposed to be doing. And this is how I help patients with lung disease. So fast forward, I had an NIH study where I looked at the next step of that program. It's called a program of support, and we'll talk a little bit about it. Patients were hungry, just like so thirsty, hungry for information. And when you think about your doctor's visit, you know, there's a lot of people in that waiting room, and you have 15 minutes, 20 minutes, 30 minutes. And if you get more than that, you're really lucky. But there's a lot to discuss in that short period of time. So in 2020, 5 years ago, I was recruited here to the College of Nursing to be the Mary Swain Endowed Chair in Palliative Care Health. So I still have my program of research, but I really kind of pivoted to be able to train the next generation. So I help lead scholarly activities for our graduate students. And we have a very strong College of Nursing. Every single student, undergraduate and graduate, receives palliative care education so that when they go out to work or their area of, if they're in graduate school, they are now deemed competent to be able to have discussions, to be able to talk to you, because, you know, we need to be able to help as many patients as possible. So that's my background. And so let's see if I go. Maybe not. I tried the arrow, it's not going. I'll just use so I do have a disclosure. I am a 1-year consultant for Boehringer Ingelheim, and it is looking at, we're looking at the literature to see what's the impact of pulmonary fibrosis and mental health. So we're in the midst of that right now. So the objectives for today. So I want to talk about this new languaging that's coming out, serious illness. What is palliative care? And what's the difference between palliative care and hospice? So by raise of hands, how many of you have heard of palliative care? How many have experience with it? How many are afraid of the word? Okay, well, I hope by the end of this, you won't be afraid. So serious illness. So a serious illness is when you have a health condition that carries a high risk of mortality or death, and it either negatively impacts your daily functioning, your quality of life, and has a strain on your caregiver. So here are just some examples, but this is not the entire list. So cancer, advanced heart and lung diseases, certain kidney diseases, pending transplantation, and across the lifespan. So we have an active program of palliative care in our children's hospital here. So we know that patients, and this is really towards lung disease, but I hear some of you coughing today. And so we know that patients experience a myriad of symptoms. This includes shortness of breath, cough, fatigue, deconditioning because maybe you're afraid to continue to do more because you don't want to cough or get short of breath, anxiety and depression. And those fall under the fear of the unknown, like what the uncertainty, what happens to me and what's my future ahead. And overall, these can all impact quality of life. So setting the stage for palliative care. These are all individuals that are receiving palliative care. And I mean, they look pretty good, don't they? I mean, it's a good marketing campaign. So what is palliative care? So according to the World Health Organization and the Center to Advance Palliative Care, this is specialized medical health care for patients who are diagnosed and living with a serious illness. And the best way to think of it is it's an extra layer of support. And the focus is on symptom management and advanced care planning. It's based upon the needs of the patient and it's not based upon the patient's prognosis. So it's appropriate at any age and any stage in a serious illness, and it can be provided alongside curative treatment, and we'll show a picture of that. It's globally recognized as a human right and an essential aspect of universal health coverage. And really the goal is to improve the quality of life for the patient and the family. So in this schema, you'll see palliative care is appropriate at any point in a serious illness. So this is palliative care in the darker blue, and this is disease-directed therapies. So let's use one of you as an example. So I heard somebody saying that they were on the biologics, and I forget the exact names. So that's helping to hopefully stabilize your disease. And you can receive palliative care alongside of this. It should start at diagnosis throughout the course of the illness. And again, here are some examples of what palliative care, what could happen is that cough that you're experiencing. Well, there's meds that there are non-pharmacologic and pharmacologic, meaning there are non-medicines and medicines that can help with your cough. If you're short of breath, the non-pharmacologic therapies include pulmonary rehab, where you learn how to breathe safely under supervision. And as your shortness of breath advances, there are medicines that can help with your shortness of breath. So that all falls under the palliative care realm. You're anxious, you're depressed. Previously, you spoke earlier today about the importance of mental health. I mean, how many of you are up in the middle of the night and the mind is just going round and round and round? It's that fear. So addressing your mental health, seeing someone and talking about it, that's part of palliative care. It's addressing those symptoms. And why is it important? There was a really, like the Game Changer study was by Temmel at Harvard, and this was released in 2013. And patients who participated in palliative care had fewer symptoms, a better quality of life, and lived longer. And so what they did in that study is this was in patients with one particular cancer. One group of the patients continued to get their, chemotherapy, whatever their treatment was, and the other group went with palliative care to address their symptoms. The group with palliative care, they lived longer. They had their symptoms addressed. So I know it's a scary topic, but it's actually kind of, I like to think of it as you're the quarterback of your team. I'm from Pittsburgh, a big Steelers fan. So, you're the quarterback of your team. You take control of it and you take care of your symptoms, and it's helping you and everyone around you, and you will feel better. So, CAPSI, which is the Center to Advance Palliative Care, these next two slides are from them. The impact for the patient and the family is it improves quality of life and it decreases symptom burden. And people who received it had more positive patient experiences. Now, for the system, what happens is that it really decreases healthcare utilization. So there's less readmissions, less emergency department visits, and even in regards to like home-based care and skilled nursing. And again, I can say to you, it's not about the money. Okay. Hospitals, of course, look at that, but that's not why we went into healthcare. We go into healthcare to take care of you. And, here's an example. If your disease advances to the point that you need to be on a ventilator with a tube down your throat, do you want that? So that's part of that advanced care planning and making that decision. You might want it, and that's totally fine, but you're the one that's in charge. So hospice is when the individual is thought to have less than 6 months to live. And it's about making the most of precious time. So what we know in the United States is that patients don't get to hospice until probably like 1 week to 2 weeks before their death. So they're missing out on all these benefits of hospice. And I always like to tell this story. We had this gentleman in Pittsburgh who he was alone. He was a retired military person, and there was he didn't qualify for lung transplant. So our doctor, he was on high flow oxygen. So our doctor said, well, let's just try hospice and see. And the patient was like, sure. They took care of his symptoms. He lived for 3 years because he had a better quality of life because his symptoms were managed. If you want to take a picture of this, there is a really good YouTube video on the Pulmonary Fibrosis Foundation that talks about the differences between palliative care and hospice. And so I like to give credit. I like to show this slide. I learned this last year at the Pulmonary Fibrosis Summit, and this was a doctoral student in Chicago. So primary care, when you get into it, there's primary palliative care, and then there's specialty palliative care. So primary palliative care is when your pulmonologist or your primary care doctor talk to you and address your symptoms and your advanced care planning. So your disease starts to worsen and you're having more symptoms. That's when the specialty team can get involved. And then the next level of care is hospice. And then the last is bereavement, and that's for the family after. So research, I'm just going to go over a couple studies. So this was a study that the protocol, I created this book called A Program of Support, and this is what we studied in patients and caregivers in 2017. It was entitled Integrating Early Palliative Care for Patients with IPF and Their Caregivers. It was funded by the National Institute of Nursing Research and Three Lakes Partner, which was a foundation. And we hypothesized that stress, symptom burden, poor quality of life, and poor care planning in patients and their caregivers could be overcome by early introduction of palliative care in the course of the disease. This is a little hard to see, but we looked at feasibility, and that's what that first column is here. The takeaway is that we had high attrition. 39% of our patients dropped out by the end of the first year, and it was because either they succumbed to the disease or they received a transplant. Feasibility was limited because we did it after the visit, and what happened is that patients were too tired. It was too long a day. they had PFTs, they had a CT scan, they waited for it to see the doctor. So we only recruited like 56%. I jumped ahead. So I go back. That is acceptability. So patients, we had a nurse interventionist who read the book to them. It's 75 pages and it stands for symptom management, understanding your disease, pulmonary rehab, palliative care, oxygen therapy, research considerations, and transplant. So it's all the information, like based upon my clinical experience. And then we did this in iterations and we studied it with the patients, and the patients really loved the nurse. It wasn't me. They really loved the nurse, and they like were craving that information. And it had an impact. So as I said, we did have this high attrition. And so what happened is patients noticed improvement in their knowledge, and there was more completion of advanced care plans, like directing what they wanted as their disease advanced. And then the caregivers noted significant improvement in their knowledge and their confidence in caring for their loved ones. It was published in the Annals of American Thoracic Society, and I just like to show this because I was new here, and I got to be on the cover of the journal, and they said, "What picture would you like?" And I thought, what better than our beautiful pineapple fountain. So this is a study was done at the University of California, San Francisco. They have their ILD clinic and they had their palliative care program. And what they did is they did a joint program, and the patients were seen by their interstitial lung disease doctor. Now remember, these people had lung disease. And they had the opportunity to participate in palliative care. And so what happened is palliative care could be face-to-face, or it could be via telehealth. And so there were 24 patients, 15 participated in palliative care via telehealth. And of all the patients, they all had advanced directives. They were also prescribed medicines to manage their shortness of breath. And then they interviewed the patients and the caregivers and the pulmonary and palliative care clinicians to better understand. And the patients and caregivers found the palliative care team to be supportive, improved symptoms, and improved illness understanding. The ILD providers reported co-management, improved patient care, but that they themselves often have prognostic paralysis. And so they're afraid to bring it up to the patient because they don't want to take away hope. So that's when I reinforce that that's when you advocate for yourself. This is the same thing. I'm just gonna, okay. Here's a study by the same group. And what happens is that these patients, they compared patients with emphysema or COPD with IPF. And what happened is that both groups received less palliative care than patients with lung cancer. And what happens is they had a higher odds of being admitted to the intensive care unit and where they received inpatient palliative care. So how do you find out if you have palliative care near where you live? This is a website called getpalliativecare.org, and it's hosted by Mount Sinai, the Center to Advance Palliative Care. And when you go there, you just follow this, you plug in it says enter your address, zip code, or city and state, and you can see if there's palliative care near where you live. So I can tell you this quick story. I had a patient advocate reach out to me, and she said, I have a woman who is in Louisiana. She asked her doctor for palliative, could she get into palliative care? And he said, no, we don't have that here. And she said, and so the advocate said, is that true? And I said, well, let's try the website. We plugged in her zip code. There were 6 places that offered palliative care within a 30-mile range of where she lived. So just because they say they don't have it doesn't mean that they don't. And you can advocate for yourself to get this. So I have to, these are our patients when I was at Pittsburgh. As I said, I led the support group, And every year we went on the Gateway Clipper, which is a boat cruise. And we did that for 15 years. It was so nice because what happened is our support, we had a golf outing. The golf outing raised funds to take our patients on the boat cruise. And as you can see, there's a mix of patients here, and that several are on high flow oxygen. Some of them had lung transplants, but we very similar to how the lunch was here today. We took all our faculty and staff, and they it was like a mandatory. You have to go. And what we did is we put faculty and staff at each table with the patients, because this was 2 hours of time that they could spend. And we used to always tell the patients, ask them any question you want, because they can't go anywhere except overboard. And then these were my coworkers at Pitt. And then now these are my coworkers here in the Advanced Lung Disease Program here at MUSC. And with that, I'm open to discussion.